Welcome to the Ortho Joe Show, a joint production of the Journal of Bone and Joint Surgery and Ortho Evidence. In our world, orthopedic research is king, and current topics from our respective publications are analyzed weekly. Here is Mohit Bhandari from Ortho Evidence and Mark Swinkowski from the Journal of Bone and Joint Surgery.
Okay, well, good morning, Mo.
Morning.
It's been a long morning for me. I've already been in the gym, so obviously I got the cup, and I hope you're.
I've got my old school cup, and Ashish, one is coming for you. I promise you that.
Exactly right. That's the very lucrative benefit of participating in these high-level discussions is you get an Ortho Joe mug. So let me introduce our guest, Dr. Ashish Beatty. He's got a lot of titles here. This might take most of our time, but Ashish is the director of the Michigan Center for Human Athletic Medicine and Performance. He is the Harold and Helen W. Gehring Professor of Orthopedic Surgery and Chief of Sports Medicine and Shoulder Surgery at the University of Michigan. He's also the head orthopedic surgeon for Michigan Athletics, that's the square M, right? We're in Minnesota, we're the angle M, right? But they're both block M's, I think. But we're the angle, you're the straight.
It's the winning M, Mark, the winning M.
Well, I can't argue with that, given the past 2 decades. But anyway, to continue on, head consultant for the NBA. Are you also taking care of the Lions too, Ashish?
I just stepped away from it for the first year, Mark. So former Lions doc.
Okay, but you also consult for many teams in the NFL and NHL. So suffice to say, a world expert in sports medicine. And Mo and I, we did a discussion about injectables, and neither he or I are true experts in this field. So we wanted to find an expert, and your name came to the top of the list. So Mo, I'm going to hand it off to you, and let's delve into the knowledge of this very bright young surgeon.
Sure. So Ashish, one question that came up, it's come up a lot, right, is in the area, and I know your expertise is sports, upper extremity area and hip, and pretty well, you cover the whole body basically with your knowledge with respect to the area of sports injury. I recall, and I look back at this around 2010, about 11 years ago, there was this big hoopla around, I guess, the pro football player Hines Ward, who had received PRP, and it led to this relative, at that time, explosion of interest into PRP. And I remember at that point looking up an article by the editor of the American Journal of Sports Medicine, who had said, don't call it platelet-rich plasma, call it platelet-rich panacea. It's being used for everything out there. A lot of skepticism early on, it's about a decade ago, but then you hear about Tiger Woods, Tom Brady. I've heard possibly Rafael Nadal, and even Ronaldo now has had some sort of they call it stem cells. It's the big, huge, area of confusion. But the one thing I did want to ask you is, you've been doing lots of work on this, and I've seen some of the work you've done related to the NBA. But what fundamentally should we be really trying to understand about biologics in sports? And specifically, what are the major players, and are we there yet with respect to these, various options for us? I know PRP comes to the top, but that doesn't mean there aren't others at play.
Yeah, those are really great questions, Mo, and I'll take one step back. First, thanks to you and Mark for having me. And secondly, I think, Mark, it's an important point to share. You kindly referred to me as an expert in this area. And the reality is, I think one step back from that is probably none of us are. I think it's truly the area that's evolving the most in orthopedics. And all of us are learning in real time. So I think the expertise changes. What I would share, Mo, to point out, and you hit it very well, is the hardest area I think about orthobiologics, in my opinion, is always maintaining your integrity to separate the perception and the promotion, if you will, from the science. And that's a critical area, because in sports medicine by nature, what brings stem cells or PRP or orthobiologics to the forefront is often the famous athlete who utilizes it. But as you know better than anyone, you've taught me, that falls somewhere below level 5 evidence, if that exists. And what we really should be making our decisions by is what's truly in the journal published by you and Mark and others, right? The level 1 and level 2 evidence. But at the same time, you don't want to be the cynic who says, well, none of that works. It is platelet-rich panacea, if you will. And then you throw away all of the opportunities that do come with it. So to, I guess, answer your later question, Mo, we're far from there yet. But have we made advances since, Hines Ward used it for an MCL sprain on the sideline? I think we have. And I think we're starting to recognize more that there are absolutely roles and areas to apply biologics. But each year, as we do better quality trials, better quality benchtop to bedside work, we're refining our indications a bit. The danger is the one size fits all. Platelet-rich plasma, for example, has some very good level 2 evidence to work, for example, for patellar tendonitis, like you mentioned for Rafa Nadal, or elbow tendonitis, or even in the situation of osteoarthritis of the knee, where it now has been shown to have every bit of the efficacy and maybe even better longevity than corticosteroid. But as you know, Mo, the danger becomes that those indications dangerously start to migrate, to use it for anything and potentially everything. And then to provide promises of regeneration of tissue or favorable restoration of tissue, which might be different than, for example, pain relief or an anti-inflammatory or pro-inflammatory response that may be very different than tissue regeneration. So I think always continuing to push the limits on knowing where the indications are, but defining those by evidence is the key, and making sure that we don't over promote. For me, the area of stem cells is probably more so the hot button than platelet-rich plasma, because that is an area where it offers tremendous promise to the patient population, can sometimes prey on hope for us to avoid the dreaded hip replacement or knee replacement. But the reality is, in 2021, am I aware of any level 1 or 2 evidence that suggests stem cells allow for restoration of cartilage and avoidance of end-stage arthritis? I'm not. I do think the promise exists as we continue to push the envelope, but there are financial conflicts out there that sometimes push us to offer these treatments when we don't quite have the science.
Yeah, Ashish, can I just jump in here? Can you update our audience on the regulatory issues that surround these two biologic interventions?
Yeah, very, very much so, Mark. As you're aware, the FDA tightly regulates the use of orthobiologics in general, and in particular, when it comes to stem cells, in the United States, those need to be quote unquote minimally manipulated. And that's an important distinguishing point from using stem cells, for example, abroad, where maybe those regulations don't exist. So, for example, if you were to take bone marrow aspirate today, or to use lipid-based stem cells today, they would need to come out of the body. They can then be minimally manipulated. They cannot be cultured. You cannot increase them in quantity. And then they need to be placed back in the patient to adhere to our principles of safety. And there's lots of experts in the stem cell world, far greater than I, that will share why we don't want that. The risk of, for example, tumorous progression of a stem cell, or ill-advised application in the wrong environment. Now, abroad, Mark, those regulations are different. They may in fact be able to be derived from other types of tissues, for example, embryonic tissue. They can sometimes be cultured up to reach a critical number. Some have referred to 10 to the 6th number of cells or beyond, offering some potential. But it's very, very important that, to your point, that we distinguish those, because it's across the board in orthobiologics, Mark, that we use these terms broadly. For example, platelet-rich plasma, I'll pick on that one. Is all PRP the same? It's not, right? We can have leukocyte-rich and leukocyte-poor PRP. We can have platelets concentrated to a variable level. We can have PRP activated or not activated. We can be delivering PRP with a scaffold or without a scaffold. And similarly, when we refer to that for stem cells, we often refer to bone marrow aspirate as a stem cell injection. But we know from good work from Scott Rodeo and others that maybe 1 out of every 10,000 of those cells is a stem cell. So in fact, how are we comparing across clinical trials when what we're using is heterogeneous, and then the environment in which we're using it, injecting it into a muscle or a tendon-bone interface or a tendon is different. So one thing that we have to do really well, and probably learn from Dr. Bhandari, is you're only as good as your studies. And so in sports medicine, I would like to hold myself, but also our colleagues to a higher level of credibility that we need to have trials that have uniformity in the application, but also uniformity in the type of orthobiologic we're delivering. Rob Laprade, I think in the journal, published a very good, important point of the so-called alignment of the MEBO criteria, which is the minimal information that we need to provide when we're delivering an orthobiologic, which speaks to these issues. How many cells? Was it activated? What was the source? So we're talking about apples and apples.
That's been a really, really important requirement that we've applied at the journal is the details of how the material is handled, prepared, and delivered have to be there before we'll consider publishing the manuscript. So sorry I interrupted, Mo.
No. I mean, just to go further, I think, there was a statement that I recall that really sort of rang true in my reading around, what's been happening. And it's fairly intuitive, but I'll read it out to you, Ashish. And I wouldn't mind getting from you your thoughts on if we were to design what we would call a high quality study, what would that look like broadly? But, the issue is the nomenclature of PRP products is notoriously confusing. And actually, because it's so confusing, it's hindered research efforts. And the challenge is no matter what you do, it always seems that there's another opportunity to say, well, that's too narrow or that's not broad enough. You haven't standardized enough. How do we actually get to getting better evidence? Even though I do know, and I suspect you're aware too, there have been hundreds of randomized trials, albeit small ones, that have been conducted in the area of PRP across the whole panacea of different indications.
Yeah, wonderful question, Mo. And I suppose to answer that, it depends a little on the application, right? Which has been one of the challenges because we have been so broad. But maybe I'll pick on one, for example. We will often hear about application of PRP for the muscle strain injury, the hamstring strain or the quad strain. And then we hear about why are we applying that, Mo? And everybody may have a different goal. A sports surgeon like me in season may say, well, boy, might that reduce the morbidity from 6 weeks to 4 weeks or 3 weeks? Whereas somebody, a more purist may say, well, is it really about that? Or is it about getting favorable healing to minimize the risk of recurrence and to maximize muscle strength and recovery? So I guess I would start, Mo, where for us, before we even think about the formulation of PRP, let's take a step back to make sure that we've designed the study the right way by homogeneity. So I'll pick on the hamstring strain because I'm involved in a study right now where when you look at many of the studies that are published, we report them as strains. But as you and I know, strains mean a lot of things. They can be mid-belly strains, proximal or distal myotendinous strains. In fact, we did a study that shows if you were to take 4 radiologists and say, grade these strains on MR imaging by a well-published BAMIC criteria, there's not even great inter-observer reliability when imaging is present. So I think the first step, Mo, is we have to pick a problem where we can identify with clarity that we're all talking about the same condition. These are all MRI-proven grade 2 strains in this location. Step one. Step two is I think then we need to have clarity in our hypothesis. Is the hypothesis about expedited return to play, like Hines-Ward, or is it about better healing of the tissue? Or regeneration of tissue. And those are going to have totally different outcome measures. And you speak about this really well, so I'll steal your own words, right? Which is we're only as good as what we measure. And so sometimes if you want to prove that PRP works, you measure a patient-reported outcome like pain relief or something that really isn't sensitive enough to pick up whether we used PRP or a placebo or corticosteroid. So we need to choose the measure in the study that's getting to our goal. If it's favorable healing, it might be imaging or a tissue biopsy. But if it's truly expedited return to play, then that's a different criteria. And then I think it actually becomes much easier, Mo, because if we ask the right question with the right outcome measures and choose a standardized patient population, then I don't think it much matters which PRP formulation we use or which stem cell formulation we use. That becomes easier to then look at those specific variables, if it's leukocyte rich or poor, or platelet rich or poor, or if it's bone marrow derived or lipid derived stem cells. The problem is we have all those variables that we want to look at in the biologic, but we start with a study design that introduces 10 other confounding variables.
That's exactly right. Yeah. And it's interesting because, back, let's say 10 years ago or even 5 years ago, you start seeing everybody was talking, and we're using PRP as one of our focus topics today, but, there were hundreds and hundreds of different, seemed to be preparations, and everybody you'd speak with would say, they don't do it the way I do. So my results are actually pretty good. And so there was never a control. The control was basically, I do something a little bit differently, and my patients seem to really respond to it. So you're having these huge spikes of interest and popularity across, hundreds of different formulations. And then you start getting into the small trials. Some show benefit, some don't show benefit, some show a big benefit. But on average, take, let's say, even NeoA, right? It wasn't intuitive that it would work in NeoA to me, at the time. I said, oh, okay, what's happening here? But the average treatment effect for PFP across all the different trials, maybe 6 or 7 at that time, the average effect was really high. But the problem is it was so variable. You could go anywhere from having a miraculous effect to almost no effect. Whereas sort of the tried and true corticosteroids, they were less effect, but they were much more stable. You kind of knew what you were going to get. And I remember thinking to myself, there's probably something here. It's just so much variability. Once it gets figured out over time, it probably has a role. And you've seen recently with the American Academy just coming out in August, upgrading PRP. I think they say platelet-rich plasma may now reduce pain and improve function in patients with symptomatic OA of the knee. That is a big change from 5 years ago. So there has been some narrowing of indications of that. And I suspect you probably, and maybe I'll ask you a very pointed question, do you believe, and I think I know the answer, that PRP does have a role in the management of patients in 2021?
Yeah, great points you made, Mo. And I'll answer that, I think, in a very straightforward way. I think it absolutely does. And that probably is a difference than maybe where we were 15 or 20 years ago, which does speak to the fact that we are moving in the right direction. I think there's no question it has a role, and it's probably a facet of, I do feel in 2021, every orthopedic surgeon's practice. There is that patient population where we don't have a wonderful surgical indication, and we're looking for a treatment option to offer that patient short of palliation. Now, the danger, Mo, to your point is that a good indication that we're indicating that patient for, or is it an indication because it's a seemingly benign intervention that isn't surgical that offers us an option for that patient? That is another question that needs to be dissected, because sometimes these procedures gain traction because they're favorable for the patient to hear that it's something pro-healing, pro-biology. It's favorable for us because we lack another tool in the toolbox, but that's different than being an effective treatment. And so, but to your point, I think it absolutely has a role. One other comment to make related to that, Mo and Mark, and I'd love your take on this, is I think another challenge for us, and we've gotten better in 2021, is I think in general, orthopedic surgeons have not had, myself included, really the intimate level understanding of biology in the way we should, right? We have some sense of, what happens at a healing enthesis or in a tendon or in a muscle. But in terms of what the fundamental principles are, we don't. We had recently done a small survey study asking surgeons, what do they think happens when you deliver a stem cell, into a foreign environment? If I injected a stem cell into a muscle, and I think even among sophisticated people like ourselves who have a medical education, you would be surprised that many believe that stem cell could potentially incorporate and become part of the healing environment. And the predominant thought among card-carrying PhDs who understand this work would say, not at all. A single cell that's injected into a foreign environment likely dies in a short period of time without a scaffold and an environment to heal. And in fact, if stem cells work, they work via secretomes, right? Via a paracrine effect on the tissue, sort of like you're delivering a local endogenous PRP. And I think all of that creates this additional disconnect, which is we as providers don't truly understand it. Patients certainly like the idea of stem cell and healing and regeneration of tissue. So there's a natural momentum in the market for us to move that direction. And I think our jobs as responsible providers is to push the limit because there is something there. We don't want to cast a net and say all of this is hogwash, but to do it in a way that actually is moving us forward and doesn't set us back by virtue of saying all of this is just a financial opportunity and little else.
Yeah, that's well stated, Ashish. And Mo, you and I have been advocates of large, simple trials forever. And I'm not sure that this is an area where a large, simple trial is even wise if it were feasible.
And I guess it gets back to, and I'm always smile because anytime you speak and you have the privilege of speaking, I chat with you all the time, Mark. So I'm speaking of you, but also with Ashish. When you speak with scholars, like people who really think about a problem, you rarely end a conversation with answers. You end a conversation with a lot more questions. That's basically what's happening, right? There's so many more questions and insights, I think, that and nuances that we have to think about. Anywhere from understanding the biology and going forward and saying, well, it works in a lab, therefore we should just try it and it probably works clinically. But I think, Ashish, what happens a lot of times is, for many practicing surgeons, is I'm seeing an effect. I'm seeing my patients happy. Figure out why it's working. Like, tell me, go backwards and say, why is this working? It's like, I don't understand it. And I think there's both sides of that story, but both sides at the fundamental level and the clinical level in terms of research have a huge responsibility for ensuring that we aren't, over propagating something that has no utility or potentially could actually be harmful. I don't think that's the case with some of our discussions, but I do think it makes us all take a pause, look back and say, how do we all continue these discussions, get as many viewpoints as we can, and ultimately try to slowly plod forward in this world that is evidence-based orthopedics.
I totally agree, Mo. And I guess leaving a little bit on a point of optimism is what a wonderful opportunity. I can say this as a sports surgeon to two incredibly capable trauma surgeons is, there's been a lot of areas where you guys have done such great work to, your criteria for an outcome is very objective. A fracture or a non-union either heals or it doesn't heal. And you have objective ways of demonstrating that on X-ray and CT. As a sports surgeon, dare I say it, right, a lot of our times our structural outcomes have a gap between our functional outcomes. A lot of rotator cuffs don't heal. A lot of times we get something to heal, but the muscle remains atrophied. So I view that, Mo, as sort of in an optimistic way. What an opportunity, because biologics will be what will likely change that. It probably won't be the next best suture anchor. It probably won't be a few more suture configurations. So I do think to your point that you left it with tons of questions, but tremendous opportunity, because how great would it be in 20 years if I said large to massive rotator cuff tears didn't have a north of 50% failure rate, and fatty atrophy of the cuff wasn't irreversible. Those are reversible. And now we understand those are the well-indicated applications for stem cells, not just a broad application anywhere and everywhere.
Yeah.
I was going to say, Mark, I'm just happy that Ashish thinks that orthopedic surgeons and trauma can agree on a non-union. I just didn't think that was a possible thing.
Yeah.
So well, I don't know where you're getting that
right. Definitely depth of knowledge difference there, I think. Anyway, Ashish, Mo and I had really hoped that you would be able to bring us up to date as to where we are. And I know that even though we haven't discussed it, that you're up to planning such trials or involved in such trials that are going to help to further elucidate what the real role of PRP and stem cells are. And we want to thank you for spending time with us between cases. Thank you for arranging your schedule, and your Ortho Joe coffee mug will be in the mail.
Thank you, guys. Thank you, guys. I would have done it for the good company without the mug alone. So appreciate the opportunity. It's always fun to hang out with you guys.
Awesome.
Yeah. Have a great day.
Thanks so much, Ashish.
You guys too. Talk soon.
Cheers.
Bye.